I'm Will Sanchez, along with our orthopedic surgeon and sports medicine specialist, Dr. Grant Garcia. Dr. Garcia, man, how you doing today?
I'm good. I'm excited. We have a really awesome topic, and just in time we'll go from F1 over here, and then we got a little bit of surgery over here. So it's going to be exciting to talk about. I do not have this many mics in front of me. Somehow the AI decided to make all these mics plus the mic on the green screen hidden. So who knows what's going on?
Yeah, so obviously we don't know how to use technology, but we try our best. So this is great. I'll try not to get distracted. It'd be like the Doc Ock thing that's happening with the microphone. But you know who we make sure we never get distracted by? It's the good folks over at the Recovery Shop. We remind everybody, visit them at shop-recovery.net. Dr. Garcia, talk about our friends at the Recovery Shop there.
Again, thanks to our sponsors. You've heard this ad nauseum, but these guys are awesome. For especially those sort of like, what extra can I do after surgery? These complex surgeries. We're going to get into some complex knee surgeries with our guests as well. But they allow people to have these sort of aftermarket options, which is great for the patients. And it actually appeases them quite well, especially after surgery when they're looking for something a little different. So thanks, guys.
Yeah. All right. So without ado, let's bring in our guests, Dr. Nick Colyvas. Thank you so much for taking some time and joining us this evening. We really appreciate it.
Thanks, Will. Thanks, Grant. I really appreciate getting the invitation to chat with you guys.
Dr. Colyvas, before we get into everything before you guys geek out on meniscus and shoulders and everything else, why don't you let our listeners or our viewers know a little about your childhood? It's very interesting, coming from a Greek family in South Africa. So just describe the childhood, how you got to the United States, and fill in the blanks a little bit, leading you to the pathway of where you're at right now.
Sure. It's a fairly long story, but to sort of summarize it to some degree, I'm going to start by saying I'm a second generation African. My parents were born in Africa, and their parents were born in Greece. So my grandparents essentially came from Greece to the United States, to Africa, and both the families grew up there. My parents met in Africa, and we grew up there. And then it was right after high school that I basically came to the U.S. My parents came to the U.S., immigrated. I stayed behind in Africa, and I went to medical school in South Africa. And there, after I finished, came to the U.S., joined my parents. And that's when I did my residency at UCSF. Following which I went into private practice for 20 years, which was great, but felt the need now 7 to 8 years ago to change things around a little bit, and just opportunities and timing and everything opened up that I essentially returned back to my training spot at UCSF. So that's sort of the broad summary.
That's great. Awesome. And we don't want it. We're gonna save your fun after school activities for more at the end of the show, because it's too exciting and we're going to distract from the rest of it. Everyone knows where we're getting in a minute, but can you walk us through kind of orthopedic surgery, why sports medicine? I mean, UCSF is a great program. Tell us a little bit more about your decision to go into sports.
Yeah, I had a bit of a tough time deciding that, to be honest. It wasn't a slam dunk for me. I really liked trauma. I liked sports, and I had some really good. This is, I think, a fairly common story, right? If you have good mentors, you have mentors who teach you things that you really. I mean, if you admire them, you kind of want to be like them to some degree. And I had some, really great guys teaching me arthroscopy, and I say this to the residents. I was where you are, fumbling around in the subacromial space trying to find your instruments. And I remember it very clearly. And I was just thinking, boy, that attending, my attending that I had was really patient, because I probably would have taken over by now if I had, if I had to watch this guy fumbling for so long. But it's just part of the process. So I had great mentors, and I found arthroscopy challenging. and something I wanted to really master. And, you know, that sort of drove me to sports medicine, to arthroscopy at least. And that's sort of what I felt like, okay, if I'm going to do something going forward, I wanted to be in essentially the arthroscopy field.
You guys are hysterical. You're the few breed that love to say, I love trauma. Trauma is my friend. You have to be built a certain way. Who can you talk about your mentors and who these folks were that to help propel you to where you're at?
Yeah, so Gene Wolfe is a name I think Grant will recognize very well. You know, sort of a real giant in shoulder surgery. Invented the remplissage, which is one of my favorite surgeries. It's the LET of the shoulder, as far as I'm concerned.
I love it.
Just added to every shoulder because it's only going to do good and not going to do bad. Just the same with an LET in the knee. And you know, he was patient with me, and he really, you know, I obviously wanted to learn, and he, you know, said, okay, look, you know, you come with me and we'll just do shoulder scopes. And at that time, I'm talking about now, this is in the 90s, right? Not that many people were doing shoulder scopes. You know, it was pretty rare. In fact, when I graduated, I was one of the sort of few people in the community that did it. Now that after that point, it kind of exploded. It was the next joint after knee. But you know, he really did that for me. Kevin Louis was another guy that taught me all about knee surgery. He was a private practice doctor, just recently retired actually, out of San Francisco. And he was the kind of person who really sort of spent the time with you and just showed you what to do. And all of these guys, it wasn't just what they did in the OR, it was also how they sort of carried themselves, both with patients in clinic and in the OR, and the kind of things that, you know, I try and do as well as I can at this point in time. And I try and teach to the residents as well.
Can you go more into kind of talking about the residents and your work? I know you did the private practice stuff for a while, but now you're more on the, you know, UCSF doing, you know, you do tons of research, lots of other things we can go into as well. Will you kind of talk about your clinical role right now? Like, what do you do? What's your day-to-day like?
Absolutely. So when I was in private practice, you know, I found it, and I was solo for a lot of that time, and then basically grew a big group out of it. But I found it that a little isolated. You know, private practice, you do your own thing, you discuss your case with your PA. There's not a lot of sort of collegiate discussion around surgery and what you're doing, etc. And so even while I was in private practice, I was actually taking time, and again, fortunate that I had the connection and the ability to do this, but to go spend 1 day a week at UCSF teaching residents. And that was seeing patients and doing surgery. So when 7 years ago I joined basically full time and I gave up the private practice, it wasn't a difficult transition. It just meant that what I was doing on my Fridays now I did for the rest of my time. And I'm generally, sometimes with medical students, but it's mostly residents and fellows. And most of that time, it's either seeing patients in clinic, but the majority is really in the OR. And we're focusing on, you know, what we do, surgical indications, different ways people approach it. You know, I'm always trying to make them think about, okay, this, you know, you've been shown this way. What about doing it this way? You know, why am I choosing this graft? Why do I add this to that, et cetera, et cetera. And that I think is sort of the major part of the training I'm doing, as you know, as part of the academic surgeon position. But there's also a bunch of didactic teaching as well. But by far the fun stuff is just in the OR. I mean, you know, everybody likes that. The fellows are always making excuses to not be in clinic and find us back in the OR, you know.
I think that's a doctor. I think that's a surgeon
just
thing.
Like we did, right?
You do a ton of LinkedIn, social media stuff talking about meniscus work. Obviously, it's a big deal. I want to get into it. Why meniscus preservation? Obviously, people, I keep pointing the wrong direction. So save the meniscus. We'll get into that in a minute. But talk to you about what's this meniscus preservation? What's your, like, how did you spur this? What's the reasoning for this? Maybe describe it a bit more.
Yeah, sure. I mean, one of the things going back to the residents, one thing I tell them a lot is, so much of life is all about timing. It may not be this was your original plan from the beginning, but I was always interested in innovation. And around 2012, 2013, the inventor of the Ceterix device, the NovaStitch device, through one of my partners, was actually looking for people to sort of help develop the prototype and test it in cadavers and stuff like that. And so I was like, yeah, this looks interesting. It's new. We don't have anything like this that, we have it inside out and we have all inside. And that's pretty much the only ways we repaired meniscus. We never had circumferential suturing devices.
Yeah. Will, can you pull that slide up while he's talking?
Yeah. And so that really sort of piqued my interest. And when I started doing more of these, I started enjoying doing more of them. And, again, it was a challenge and it was interesting. And this is a picture of, this is one of the bigger ones, right? So this is a lateral meniscus tear that has essentially a horizontal cleavage component and with a circumferential suture. And this is actually, this slide's kind of interesting because there's 3 different techniques here. You can't quite tell, but the posterior horn is all circumferential technique with a NovaStitch type device. Then the mid body is actually all inside. And then when we come to the anterior side, which is difficult to get the instruments to get either the circumferential or the all inside techniques, you do an inside out technique here to repair the anterior horn. And this was a full round the clock horizontal cleavage tear, which is unusual. Normally it's a section and you just put in maybe 4 or 5, but I think we put in about 11 here. So this is one of the bigger ones. I'm happy to say his patient's doing great and all is good. But this is sort of the thing that I think, certainly when I started training, we would never do anything like this. And I think over the course of the last 10 years, you see more and more of this, rather than just take out this lateral meniscus. And, partial meniscectomy on the lateral side is really, really
not
tough.
good.
Yeah, it's not a great result. So saving this meniscus, I think, becomes quite critical, and we have the tools to do it now. But you have to kind of commit to it, right? It's so much easier to do a meniscectomy. I can save myself an hour in the OR by just chomping this thing away. But I think that we are getting to the point where many people are looking at this and saying, no, it's repairable, and let's give it a try.
I think this is an interesting topic. I mean, the thing that's interesting too here is we see this a lot in discoid meniscus.
Absolutely.
I think and those are ones that are kind of nasty. They end up with transplants. I see them for the transplant. I see them for the discoid initial conversation. Do you have any, we're not sidetrack the conversation, but do you have any specific thing you talk to the discoids? Like in my office, a discoid comes in, I'm like, listen, this is not just a normal meniscus. This is going to be a different animal. And these things you showed may be employed. How do you have that conversation with them initially? And then kind of how do you talk about the outcomes to them, right? Because sometimes these people have seen 4 docs and all of them said removal. And you're the only person that said, we're going to try to save it.
Yeah, look, I mean, I spend, with any meniscus patient, but with discoids particularly, I spend a fair amount of time, and I like to draw it out. I like to show them the C shape and the D shape of the meniscus. And I explain to them, what it involves when we sorcerize it. And I give them the terms so they understand it. And then I tell them, when you sorcerize it, almost always you're going to have a horizontal cleavage tear all the way around, and that should be repaired. It shouldn't be removed. And I think the outcomes there obviously are going to be better if you do a repair than if you do a resection. But I do tell them, look, your cartilage on that lateral side has never really seen normal forces, and okay, most of these patients are still sort of in the younger group, but I've even got older discoids that come in, and it's been unrecognized for a while. And your cartilage has never seen that the normal forces that a normal cartilage would see. So when we do all of this, or as a result of the tear, it may not respond like normal, and we may be talking about early arthritis, et cetera, et cetera. So I do, I don't give them the oh, we're going to do surgery and everything's going to be perfect. That is, I think, with discoids, all bets are off. Many of them do great. I mean, I over the last 10 years, I've done quite a few now with repairs, and I've been very, very happy with it. I think it's 10 times better than, just taking it out.
I have a question for you too. I've seen your LinkedIn posts; they're pretty awesome. I do complicated meniscus ones, but you take on some things that even I think I look at and I'd say I'm not even sure I could fix this, which is really great. It's nice to see. It's refreshing that you show your stuff.
I appreciate that comment coming from an expert surgeon like yourself.
But anyhow, so yes, so how does that go for you? I mean, obviously, right? You're with the residents and the fellows, and they're seeing you fix a meniscus, and they're like, "This is really cool. I'm excited to be here." Right? But you're posting that stuff online that's already a little out there, and you're showing pretty awesome results and pretty cool things. You're really pushing the envelope on this. What encouraged you to get to this level, right? Because like I said before, you're showing people that even the people that do a lot of these, that they're still not doing enough.
Yeah. I think that it's a evolutionary process. I think 10 years ago, I wasn't pushing as hard as I do now, in terms of what I'm going to repair versus resect. I think, obviously we show the ones that are interesting, and they tend to be the ones that look difficult and that we're still able to repair. I will say behind the scenes, there are some where I just look at it, I say, I just cannot do that one, or I can do it. I mean, what I tell patients oftentimes, look, most times I can technically repair your meniscus. I can, put it back together if it's just a technical exercise. But it's a decision between whether or not you can technically do it and whether or not there's a high likelihood of it healing, right? So some of those meniscuses are pretty beat up, but either there's, the arthritis, or the alignment's not right, or the patient's overweight, or all the other factors. It's not just the meniscus, it's everything around the meniscus. If those factors aren't correct or, favorable, I think you've just got to, it's a judgment call. But what I found is that as I've done more and I've done things that, I've said, maybe this one's in the gray area, and I fix it and the patient does well, that encourages you to push forward more. It's a slow process.
And how have you think these techniques improved over this? Because you mentioned this 10-year period, right? But what's different over the last 10 years? I mean, I know you've gotten more experience, right? That's great.
Yeah.
But what do you think's evolved? You mentioned something about, one of the NovaStitch device, and that's just one part of it. What do you think's gotten to this point where now you're like, okay, maybe I can fix these now, and maybe they're going to do better, right? It's just research and things like that, but there's more to it.
Yeah, so I think the biggest advance we made in the last 10 years, and everyone kind of laughs at this a little bit because it's not like some fancy new device. It's MCL pie crusting. I think that has allowed us to take on repairs because we have access, because we have the ability to actually get to the tears and get to the posterior horn and really get the sutures where they need to go. I think that's given us the ability to take the existing techniques inside out, outside in, and really, sort of leverage them to the maximum. I think the other thing is that we're better at, and there's still lots of room for improvement here, but we're better at using biologics, whether that's marrow venting, whether that's fibrin clot, whether it's PRP.
Will, can you bring up that fibrin clot thing while he's talking? Sorry, keep going.
All of those things that are the the sort of second part of this, which is, it's obviously when you're talking about repair. So when you're talking about preservation, it's okay. First of all, which ones do you repair? Which ones don't you repair? If you're going to repair, then you have to get the mechanically best repair you can possibly get. And then the last piece to it is definitely the biology. You've got to maximize the biological environment to really sort of improve your outcomes, basically. And so this picture is a fibrin clot. I like fibrin clot. Dill Cannon taught me how to use it 30 years ago.
Will you describe it for the patients? Because I don't even know, some of us don't even use it. Some people use it more than others, and there's a little trick to it. So maybe you could describe it a little bit better.
Sure. So Fibrin Clot, like I said, it's not a new technique. When people started repairing meniscuses arthroscopically, I'm not sure. I think Henning is really the first person who did it. And essentially, it's taking the patient's own blood and then using that blood once it's clotted, and you clot it on a glass rod because that's how it clots better. It forms this fairly robust. I mean, people think of it as a blood clot as quite unstable and difficult to work with, but actually it's more robust than you think it is. You can tie sutures into it, and that allows you then to shuttle it into a position. So what I do, this is a horizontal cleavage tear, for example. You pass a shuttle suture on one side through the middle of the horizontal cleavage tear, and then one on the other side. And you shuttle this clot in. You've sewn it now with the suture, and you attach it to the shuttles, and then you shuttle it into place there, and then you place your sutures on top and bottom, and you kind of zipper it closed with that Fibrin Clot in there. And there's a description out of some Australian surgeons as the jam sandwich. So basically, it's your 2 leaves with some jam, with some strawberry jam in the middle there, and that jam sandwich, I think, provides the mechanical strength that I'm talking about. And there's tricks about putting in as many sutures as you need, not just 1 or 2. You've got to put, for a tear like this, I think you'd put in 4 or 5 at least. And then maximizing your biological environment as much as possible to get that to heal.
And how are you deciding? Is that all your horizontal tears? Like, who's getting the Fibrin Clot? What's your decision-making process?
Yeah, that's a great question. It adds more time. It adds more complexity, right? So I think the horizontal cleavage tear is a good choice, and I do the Fibrin Clot now, I would say, more and more. Is it most of my horizontal cleavage tears? No, but it's more and more, and I'm doing it more actively. I'll also do it for any radial tear. At this point, a radial tear, I think, is a really difficult clinical problem. They're born trying to die. They're constantly feeling the axial load on their hoop stress to pull them apart. Horizontal cleavage tear actually works the other way around. Your axial load is actually pushing those leaves together. The radial tear is the opposite. So I will use Fibrin Clot for that. I think things that don't need it is like a root tear. I've done it just to show that you're clinically able to do it. But I think a root tear, you've got a tunnel, you've got enough blood in there. I don't think you need a Fibrin Clot for that.
Is there a specific age group that you kind of focus on, or a range for you to do this procedure, or does it not matter?
I don't think it matters. I don't think there's any specific age cutoffs, except that there's certain types of tear, like the root tears are all older patients, right? The medial root tears are all older patients. But any patient I have a concern about, maybe it's an older tear or the tissue quality doesn't look great. Once you get your anesthesiologist and your surgical staff to sort of know that this could be a potential thing. It's not suddenly, oh gosh, now we have to draw blood. Now we have to stir it for 15 minutes. There is a process, and it does add time to your surgery. But the more you do, the more everyone becomes familiar with it, the easier it is to just say, hey, this is what I want to do it on. I mean, there are many that I will just decide beforehand and everyone knows, but sometimes I'll be in there and I'll say, I just want to add a Fibrin Clot.
So the age might come into play if it's, depending on time under anesthesia or some other factors, right? That's where you made a decision, whether it's yourself or you and the team, if you're going to do a procedure like that.
Yeah, I think all of those factors come into it. Time under anesthesia is probably not the one that I would focus on heavily, but really it's the nature of the tear. I mean, you could see like this tear. The cartilage surface is excellent here, but that meniscus is awful. And I would want to do everything I can to try and preserve that meniscus, because that's the whole goal here. The meniscus is there simply to serve the cartilage. It is the cartilage protector. The whole goal here is cartilage protection. Meniscus preservation is all about protecting cartilage.
Perfect.
And what do you? This is a good concept. We just recently we had Cole on, and we kind of talked about the same thing, but talk about sort of the idea of preservation, right? I mean, you're preserving the meniscus, you keep saying, but there's other factors at play, right? Age is one of them, but they're talking about, you're looking at all these things, right? Alignment, how good the cartilage is, and that all has to be part of it, right? What's your kind of algorithm that you look for? What do you, when you have a care like this, right? You're not just looking at that tear. You have a discoid, you're not just looking at the discoid.
Absolutely. So every patient, I think this is a little different maybe to some of my partners or whatever, but every knee patient I get gets an alignment film. I think that's critical. I think you have to know what that alignment is. I think if you're trying to repair a tear and the patient has, 7 degrees of varus alignment, you're just doomed to failure on that side. You got to think about doing an osteotomy, and there's lots of arguments back and forth, but I'm looking at the important things are alignment, cartilage quality, and stability, right? And you've got to have if you don't have an ACL that's working on that side, don't fix the meniscus and leave the ACL unfixed. You got to do both. The ACL and the meniscus, particularly the medial meniscus, do an intricate and intimate dance together. They need to both be fixed, and that sometimes is not meniscal preservation, but meniscal replacement, right? Putting in a transplant. I just did one today. I see these. I like you do. I see a lot of we see revision ACLs, and time after time, I see this failed ACL and someone who's had, more than one meniscectomy. Well, after you start taking out one meniscus, bit of meniscus here, bit of meniscus there, you really got to think about a meniscus replacement, and you really got to get, meniscus replacement, I think, can be a difficult surgery, and people kind of shy away from it because of that, but you can't just go back in there and put a new ACL. So stability, cartilage quality, and alignment are sort of my 3 big ones, and lesser ones, they're more important to me than BMI and age. I think those two, certainly come into play, but they're, if I have someone who's older and heavier, but all those other things are perfect, I'm more likely to say, yeah, we're going to go for it. We're going to give you a meniscus repair.
Got it. How do you, this is an interesting we have similar practices in terms of the complex knee stuff. So a patient comes into your office, right? You're maybe second or third opinion. You're UCSF, so they're probably coming in that situation. And they come in, they're told they needed a small meniscus repair, and all of a sudden now you're telling them they need an HTO, and then they need to have this as well. Like, how does that conversation go? Usually it's, there's a little deer in the headlights, because you're doing limb lengthening films, that you're not you're one of the few guys that probably does it in that area routinely, and you're catching way more things than you think. So how does that conversation go? Like, how does right? Because they're like, I came to you from a meniscectomy, and now you're like, well, you need to have your meniscus replaced or ACL or something else. You're smiling. I can tell because you've had it before. So I'm curious how your approach goes.
So 2 things. Happens a lot that I see a patient and they've not had, they've seen 2 or 3 other surgeons who've not had alignment films, and then we catch a significant amount of varus, on the medial side if we're looking at medial meniscus. And I would say that most of my patients come to me because they know that I'm likely to be more aggressive about repairing a meniscus. Because patients, this is another, there's a bit of a sidebar here, but patients are typically well-read, well-educated, sort of researched. And they are the ones who drive the idea that I don't want a meniscectomy, I want a meniscus repair. And so they naturally seek out people who, have some kind of a reputation for being more aggressive with repairs. So I don't get the many that say, well, I don't need, I just came to you for a meniscectomy. But, when we do have those that I say, I think we're going to have to realign you. You just, otherwise your transplant or your MACI or your meniscus, repair is not likely to work. And then I explain what an osteotomy takes and how it's, it's not the world's most fun surgery. That's when you get the sort of, wow, are you sure? Are you sure I need that? Well, I was like, look, I think that's the recommended path I would take. I don't, say I'm not going to do surgery on you unless, but I would say it's the recommended path I would take. And I just worry that if we don't do that, anything else we do is going to have a high failure rate. And, patients get it.
Do you find what I find interesting is that conversation you just had. Sometimes they're like, I don't know. And then about 2 months later, they come back and then they're ready to do it because they've done the research now. And they're like, wait a second, that's actually the right answer.
Yeah.
I just haven't heard that before.
They may have seen someone else in the interim as well. Not only have they done the research, they've gone and had one or two more opinions, and they've sort of figured out either that guy didn't even get a film, or somebody got the film and said exactly the same thing, and that's it. So I think the alignment's the one big thing that probably needs, that's kind of thing I'm drilling into the residents and the fellows now, is be comprehensive in your evaluation. It's not just what the MRI looks like.
Speaking of the meniscus stuff, I want to talk. You had mentioned something previously. We were talking about some meniscus transplant stuff. Do you have any memorable cases or things you can talk about? Like, what's your experience with meniscus transplant? I know you do a lot of them. Is there? Yeah. What's your thoughts on that?
I enjoy meniscus transplants. I think they do well. I think the data continues to get better. I think we were quite pessimistic about them in the past. I know when I first, 20 years ago, it was always more like a salvage procedure, right? It wasn't like we're going to return you to sports. I think that some of the latest data I'm seeing where 50% of patients are getting back to high-level sports. I mean, that's, it means 50% aren't, but 50%, many of the other ones that aren't are getting back to recreational sports. I think the results are getting better. I think that, and this is now sort of a personal feeling of mine, moving to all soft tissue technique rather than, dovetails or bone plugs or whatever, makes the surgery easier. There's data around extrusion that shows that you still get higher levels of extrusion, but the outcome data for patients with meniscus transplants shows no difference really for either bony procedures, plugs, or dovetails versus soft tissue. So if you do think about doing a meniscus transplant surgery, if you're a surgeon who's thinking about it, and you're put off because the ones you saw in residency all took 4 hours and there was lots of swearing in the OR, and you do them sort of in a simpler, easier technique, you're going to start doing more of them, and I think that's going to serve patients well. The other side of meniscus transplant is, I think, there's a tendency to get to it too late, right? There's data to show that it's probably better getting earlier before the cartilage changes have happened. You're going to get that chondroprotective effect and probably more longevity out of your graft. And so that's my sort of philosophy around the meniscus allograft. I think that once you do, the more you do, the more likely you're going to find those indications that you will say, this is going to benefit my patient.
Is it from a teaching perspective for transplants? This is really interesting. So I was trained by Cole, started off doing meniscus transplants, and first couple were a couple hours, 3 hours, 2.5 hours, and he did it in 45 minutes, and I couldn't figure out how. And then eventually do you teach them anything? Like, the point you made is really interesting, right? Because I'm still a dovetail bone plug. I've leaned toward a little soft tissue in the anterior horn with ACLs because I'm so tired of getting anywhere near that tunnel. Do you teach your the point you just made there is like, if you're going to do nothing, it's better to do this, right? Do this option. And the other thing is, like, if you're the first few years out of residency or fellowship and you start doing meniscus with ACLs and cartilage, like, you're gonna never leave the OR, right?
Yeah,
so
I think.
How do you teach them that stuff? That part's really interesting because that's not something like I would have never tackled. I remember my first one took like 6 hours. I did one last week and it took under 3 with 3 different things. So it's like, but I would never have tackled that first week or two in fellowship or in practice.
Well, I think some of it's obviously your training, right? If you said you trained with doing bone plugs and dovetails, and the person you trained with does them really well, does them really slick. You learned that technique. I think that's great. And what I'm trying to do is teach the residents a technique that they can get comfortable with as quick as possible. And, I mean, I don't, their first ones are also going to take longer, but I think that they're going to say, oh, this is something I trained. Our fellows come out having done, I don't know how many, but enough that I think they would tackle it in their first job, quite without too much difficulty. So I think it's partly the technique, but it's also partly getting the exposure when you're in training. They need to see a good number of these done well. Whatever the technique is, that particular technique done well. I think the fellows need to see a good number of those, be involved in a good number of those, and then they will be able to basically take that to their practice.
I think it's an excellent point you brought up in terms of they need to see it done well and they need to see good outcomes, because, we're up here too. You get the same one. The patient comes back. They said meniscus transplants don't work. I'm like, we have testimonials. Look at it online. You can see people do well. You just have to do a good job. But it's an interesting one, because it's still definitely one of the more stressful cases when you add a bunch of stuff with it. But the results, if done properly, are impressive. But that's a really important point you brought up there. It's anything we do, right? Well, we train, and if we don't see it done well, or we don't see good outcomes, then we're probably going to be nervous to do it for a while.
Yeah, they shy away from it, which is a bit sad. But that's brings in the whole sort of concept of how do you make a really good fellowship.
On a personal question, not to be a Debbie Downer here, but I'm always curious. Like you do so many cases, so many surgeries, you work with so many people. What are the most difficult cases for you? Is it maybe a single parent that has kids that have to get back to work, they're struggling with an injury, or maybe someone at a certain age, that's going to affect their quality of life? With all of your experience, you've seen so much. An athlete, a professional athlete, or a collegiate athlete that was ready to go pro, but had an injury that now has curtailed that dream. What are some of the difficult things that you have to deal with, and how you manage that, and how you communicate that to your students, and how to go about their, how they go forward?
Yeah, I think a lot of that is how much energy and time you allocate right from the beginning, right from the first moment you meet the patient. So, I mean, Grant and I think at this point, the minute we walk in the door, we can already see usually the patient who has a complex problem. We kind of can get that first sense. And then, and again, most of this happens outside of the OR. Most of what you're asking about, how do you assess that, et cetera, and what's going to be difficult and what's not, happens in your clinical visit, in your clinical time, which is why, of course, we try and get the fellows in clinic as much as possible. But because they need to see the stuff, because what you need to do is then, as you're engaging with that patient, you're determining, hey, look, this person's come in, they've got all the support they need, they've got all their social determinants of health are great, they've got a problem that's relatively easy to take care of. I know I can do this. They trust me. I can tell already that relationship's building, et cetera. Those ones need a lot less time than other ones that are, have difficulty and have issues, and you just need to allocate the time. The thing is, your clinic setup is, you've got however X many minutes per slot, right?
Mm-hmm.
And you can't just say, well, everyone's going to get the same amount of time, for example. You have to allocate the amount of time, and then if you can't, you have more follow-up visits before you do surgery or whatever. I think there's just a lot of things that you need to sort of do to really be sure that your patients are, number one, trust you, and number two, have their expectations realistic. Okay, I think that's where we run into a fair amount of problems. Some patients come in and say, look, I've got this ACL tear, and I see that all these patients are doing well after ACL reconstruction, and that's their expectation. You're going to sit down. Well, look, actually, you have some arthritis. Your meniscus is trashed. We can probably do a few things here, but I want you to expect that you're going to have this outcome, not something that you've heard from somewhere else. In my experience, this is what is likely to happen. And sometimes that's a difficult conversation, but it is one, I think, where you have to make that assessment. And I can say most of it, all of that happens before you go to the OR. And then you have to perform a technically excellent surgery. And most times, not always, you'll get the result that the patient expected and you expected. And then you got to throw in the wild card of complications, which always gets you.
So I'm assuming that's also part of the conversation that you're having with your fellows, not just the technique and everything that you've learned, but also how to manage, because it's a stress, right? And how to manage that in order for you to have a successful career.
Absolutely. And we'll do debriefs after clinic. We do debriefs after surgery. We do debriefs after clinic, and I'll pick out the tough ones. And I'll say, look, did you notice during that conversation the patient's eyes glassed over and they didn't understand a word I said? Did you see why I went back to something else and that? Or I'll say, what else could we have done for that patient? What other choices do we have? And sort of just try and break all of that stuff down. I think, fellows get it. We all got it. It just was like, you just need the exposure to it to see how other people do it. And actually, talking about training, you have to see how some people do it badly too, so that okay, that's not the person I want to be, or I'm never going to do that with a patient. That's also part of training.
That's great.
Yeah. I do want to make sure in the essence of time we get to a couple more things that are really interesting. So I know we could talk about meniscus saving for probably like 3 or 4 more hours, but I would love at least. So can you talk about your work? Can we pull up his thing on Convergence Medical? I'd love to know more. Actually, we don't have time for this. We'll go to the next slide. We're gonna be here all night.
That's more meniscus. If I know my meniscus, that's a meniscus topic. Yeah.
Can we do the Convergence Medical to learn more about that? So why don't you tell us, you've served as chief medical officer for this. This is it's a really interesting company, et cetera. Will you give us a little bit background?
Yeah, I'm happy to plug the company as long as you want as well. I'm happy to talk about it. But, I think the interesting topic here is robotics in arthroscopy, right? We are behind the 8 ball compared to our arthroplasty colleagues who've been using robots for a long time. And we're way behind our general surgery and our urology colleagues who now, if you need your prostate out, you're going to get it out by a robot. I mean, that's basically the way it works in the US today. So there has not actually been very much, if any, sort of work done around using robots for arthroscopy, using robots for essentially 2 major components. One is the navigation side, kind of like our arthroplasty surgeons work, and where we would do that in arthroscopy, pretty much the use case. I mean, it's not the only case, but sort of the most obvious is ACLs, right? So ACLs, everyone says 40% or so. You and I see a lot of revisions. A lot of that is tunnel malposition. So we can get an arthroscopic robot that will show us where the ideal tunnel placement is. Not actually, we will control that, but basically gives us a tunnel assist. I think is one place where robots could really help. And Convergence is not the only company that's working on that. You're aware of Smith & Nephew's Tessa system. And there's a company out of France called Canistra that already has a robot. So Canisca. And so this is a kind of a hot topic. That's the navigation side. But what is a Da Vinci machine? Da Vinci is now an absolutely massive company. Our general surgery residents cannot graduate without being robot certified by Da Vinci. So it is, it's a big deal. They're a massive company. Robots are huge in general surgery and urology. But what they do is they give you dexterity, right, with 3D vision. If you've ever looked down a Da Vinci screen and seen what you see compared to what we see with our 2D vision in arthroscopy, it's a bit of an eye opener, literally. So they have dexterity and vision that we don't have, and that would really significantly, in fact, it's probably even more important for us in the joint, because we're working in very tight spaces, trying to move an instrument around. We're essentially one-handed. If you think of an arthroscopist, one hand is always on the scope, right? Or more or less all the time, unless you're doing something a bit strange and you've got a fellow helping you, whatever. But the bottom line is we've got one hand on the scope, so we're one-handed surgeons, and we really should be two-handed surgeons. So this is just the sort of basic outline of potential for what robots could do, but it's very hard. It's really, really hard. It's figuring out how to make the robots do what you want to do, and figuring out the best use of the robotics is really difficult. We've got, like I say, Da Vinci's been at it for a long time, and so there's a sort of path that we can follow. But there are, I think, some significant opportunities for us in arthroscopy to use robots.
That's awesome. I mean, people ask that. We had this conversation. We had an AI topic from the podcast, and people were interested in, you're saying, doctors are going to be robots. And like, no, the idea is assist. Like you keep saying, it's like, better vision, better dexterity, navigation. I mean, maybe the future, but at least for now, we want things to be more accurate, right? Because then we avoids revisions situations.
Yeah, that's exactly right. So there's a I think the ACL is sort of the poster child for, this is a place we could really use it well. But like every other technology, once we start using it, we're going to find all the other places. I mean, there's lots and lots of different things robots could do. I think that question about whether or not they'll actually take over completely from surgeons is interesting. Elon Musk posted something about that recently, that they're gonna do all the surgery. I personally don't think that, but look at, you don't have Waymo yet in Seattle, right? But
well, my one of my best friends was a designer for them, so I know a little bit about it.
Yeah, they're in California. You see them all over the place.
I mean, you'll see like at an intersection, 4 of them. I mean, it is like, that's how people get around here. And they just released their statistics showing that they are the safest drivers out there. They're better by leaps and bounds of human beings. So I don't know, maybe you will just press a button and you'll get your meniscus repair. But I think that's going to take a long while. Yeah.
Will, let's show the fun stuff. So again,
that's what I was saying. It was a segue. You're talking about these drivers.
Speaking of drivers and safety,
look at this guy.
Tell us a little bit about this.
So this was so I've been crazy about race cars all my life. And it wasn't until I finished residency, went into private practice, actually started making a bit of money that I could actually indulge in this hobby/passion. I've been doing it for 25 years now.
Wow.
I've raced tons and tons of different types of cars. I've done a lot of racing. This particular picture was 2019. I did a year with IMSA, this is an LMP car, so Le Mans prototype style car. Wow. This is a modern car, modern race car. It has all the electronic aids. Everything is push button essentially. You got a steering wheel, you got paddle flips, you've got steering assist, you've got all kinds of different. There's 7 pages of data on the steering wheel that you can scroll through to see what everything is. So this is a sort of a modern race car, and this was a fun year. It did reinforce that I'm not a pro race car driver. On my team, you'll see there's a big. We had 2 cars, and these are endurance cars, so you get a driver change as well. And on my team, we had 2 pros and 2 amateurs.
We'll show that picture.
Being myself. And the bottom line is, the pros were always just that that bit faster. They were always able to do it. We put it this way: we benchmarked our performance against what the pros were doing, and everything. All the data is logged, everything you can see exactly when. And then this is kind of what I do more of, which is single seater racing. So that's the last car was a closed cockpit. This is single seater racing. This is a Formula One car from the 70s, and this is at Monaco, and we race there every 2 years or so. I've done it like 5 times now. Wow. And this is opposite, right? This is a lot of power, a lot of tire, and all analog. So there's no steering assist. Your brakes are not power assisted. Your gear shifting is, a H pattern gear shifter. You've got a clutch. All of these different things.
Real driving.
Yeah, that real seat of the pants driving.
Yeah.
And so
can you talk about the Monaco race itself? I mean, obviously it's different depending on the format, but why do you like this particularly? Or I know this is a cool picture. Everyone knows Monaco, but can you describe it a bit more?
Yeah. So I think, Monaco has its own sort of, really, it's got a very different feel, right? There's no other races like Monaco. You're going through the streets of the Principality. From a race car driver point of view, many street circuits are a bit they feel they don't have a lot of good rhythm or a good style to them, because they're basically streets that have been squared off. And the other thing about street car races is there's no runoff room, right? You make a small mistake, and I've done this, unfortunately. You can be 4 inches off the line, and you'll get a steel barrier that you hit. On a regular racetrack, you'll have a berm, you'll have a barrier, like about 6 feet or sometimes 50 feet away. You've got room for runoff if there's a mistake. At Monaco, you don't. But what's interesting is, even though it's a street circuit, it has a really great rhythm. It's almost, they did it in 1929. I'm sure they didn't have so many professional designer do it. They just closed off a bunch of roads. But it has a fantastic rhythm to it that really just, you just, once you get in the zone, and that's all racing is all about getting in the zone. Once you get in the zone, that thing just flows. It's just such an awesome track. But you can't make a mistake.
What's on the bucket list? Have you been to the 24-hour Le Mans? Have you, gone to Abu Dhabi or any of these amazing racetracks? Go ahead.
I haven't done Le Mans, but I've done most of the other tracks. I've been, we get invited to do some of the Prix races for some of the F1 stuff. Nice. So in the US, that'll be like Coda. There, and then I've done Montreal, I've done Suzuka in Japan, a bunch of European races. So I would like to do Le Mans, but Le Mans doesn't do single seaters. It's all Le Mans cars.
Yeah.
And my preference is single seaters, and all of my cars are single seaters right now.
Who's your favorite driver right now?
Who do I think is the best driver? Who is my favorite driver? We're talking about.
I think we're going to say Verstappen, right? He's pretty much has dominated. But who's your favorite driver?
So I like Piastri, huh?
Okay, Piastri.
I think that he is cool, calm, collected, and gets on with the job. A little disappointed with his second half of the season.
Yeah.
He was heading there, and then I don't know, he just kind of fell off a little bit. But I think overall, you watch some of the things he does, and he's obviously knows what he's doing. He's got the talent. But right now, I think in F1, it's just hard to say that anyone other than Max Verstappen has that level. He is just a force of his own.
Yeah, that whole Red Bull team, they've got it. They've been dialed in for the last few years with their cars and technology.
Well, I don't know about recently, huh? I think that they have been in the past, no question. They were always 1-2, right? But now it's the pure force of Max Verstappen that's keeping at least one of those cars up front.
Yeah.
The other one's not always there. Or in fact, not a lot there. This last year is, there's a massive differential there.
Yeah.
Again, we did it again. We're close to the end of the time.
No worries.
I don't want to sidetrack, but before we let you go, the next 5-10 years, what do you think holds for joint preservation and meniscus repair, etc.?
So I think biologics are going to get a lot better, right? We're going to figure out what really works. Is Fibrin Clot as good as I think it is? Are there going to be some other magic things that we can, first of all, either inject before, or basically never do surgery and just use injections? Maybe intrameniscal injections. We've been doing a few of those. There's some data out of Europe that's pretty good for PRP intrameniscally. But I think all of that's going to develop with more time for sure. And so again, I think we're going to do less meniscectomies, and then when we do repair, I think we're going to do better with some of the techniques we have now, but with biologic augmentation as well. And then I think there's always innovation that's coming. It's always interesting to see. I think meniscus transplants will continue to get better, and there's 3 companies out now that are working on synthetic meniscus transplants. Yeah. None of them are proven. None of them, they're still all, probably 3 or 4 years away from FDA approval, but they're all working on it. It's all coming. It's all going to be, down the line here.
Cool. Well, thank you so much.
Thank you, Nick. We really appreciate time. Dr. Garcia, man, we needed more racing talk. Man. You just come on.
I didn't want it. I knew it was going to happen. If I kept going, we were going to be way over the hour. I was trying to be nice.
Oh, man.
Don't get me started. We'll have to have a whole separate podcast on it.
Oh, I love it. Do you have a race simulator at home?
I don't. So what I use is a go-kart, a racing go-kart. Okay.
Okay.
That is as physically demanding as any F1 car. I'll tell you that. It's better than a race simulator, but I know that lots of people do, but I'm not I can't sit in my bedroom and do racing. I have to be on the track.
I love it. Nick, thank you so much for your time. We appreciate it. Thank you so much.
Thanks, Will.
Thank you.
Thanks, Grant.
Dr. Garcia, man, we've done it again. We're so thankful for the doctor to join us as we wrap it up. Just remind everybody, check us out, sportsdoctalk.com. Check out our episodes, transcript of the show. You want to be a guest, you have questions pertaining to patients, questions to other shows, anything like that. We really want to thank everyone, including our guests, so much. Dr. Garcia, I'm racing through it so we can manage it. Say goodbye, say something.
Thanks, guys. Really appreciate it. Check us out. We get guest requests. This is awesome. You never know what we're going to show, never know who's going to be on. So this has been a really good year for guests. This is it's exciting. So thanks so much for Dr. Colyvas coming on. This was great.
Vroom, vroom.